future of healthcare has arrived. Artificial intelligence and machine learning are transforming the practice of medicine and improving patient outcomes. This is Smarter Healthcare with AI. Conversations with Dr. Tetteh as he shares insights into the healthcare of tomorrow and how we can help create it today.
This week, I'm thrilled to welcome David Sontag, a trailblazing figure in the intersection of artificial intelligence and healthcare. As the co-founder and CEO of Layer Health, he spearheads a groundbreaking initiative to leverage AI in unlocking the potential of unstructured medical data. David's extensive expertise extends beyond his leadership role, and he holds a distinguished position at MIT, where he has authored over 100 influential publications in AI and machine learning. David, it is indeed a pleasure to have you on the podcast today. And I must say for the audience as well, we met each other in person at the august campus of MIT, specifically at the Broad Institute, during a summit, if you recall. It seems like many moons ago, because anything pre-pandemic is almost like BC. It's like so far away in everyone's memory. But it was at that summit that we had convened a mastermind of intellectuals, academics, technologists, and AI experts to talk about how we could take this repository of immense data in the Joint Pathology Center, as you recall, and digitize it for the greater good. And that conversation, of course, was really engaging and quite inspirational. And we had some time to sit down and talk. And I've been following your work ever since, and you've been doing amazing things. So it's really a pleasure to have this conversation with you right now. In 2024, post-pandemic, I guess one of the ways I'd like to get started is, what has changed since that time that we met? That's a big question, but of course, I know you have quite a perspective on that. What has changed in the last few years with respect to AI and healthcare in particular?
First, thanks so much for having me on this podcast. I've been really enjoying listening to the first couple of episodes. So yeah, it's been quite a journey in the AI field for the past few years, both as an academic and an entrepreneur. The technology has evolved substantially. So our company is built on large language models, which didn't exist 4 or 5 years ago, and has just completely revolutionized the way that we tackle problems involving language and vision. But then moreover, I'd say the whole entire field has changed as well. Field meaning the healthcare field. The willingness and appetite to bring AI into the clinic is unprecedented. And then if you ignore the AI element and just think through some of the data elements, the maturity of healthcare organizations in the US, both of course private and public, has transformed and made it possible to actually start thinking about, how do we integrate at scale? How do we move beyond just thinking about data interoperability to actually changing the point of care and beyond?
Sure. So technology absolutely has changed. As you mentioned, large language models were not necessarily on the tongues of everyone at that time. The appetite, which is an interesting observation, because I agree with you, the appetite for medical organizations, health practitioners, to embrace technology and AI in particular now and incorporate it into their practices is unprecedented. It never happened in my experience, years ago. I think one of the questions that certainly I'm interested in, I think the audience would be interested in as well, because I think it will set context for the rest of our discussion, is how did you get involved in AI and machine learning? Obviously, you've been doing this work as an academic, as an intellectual for many more years before all of this, sort of became the zeitgeist of the discussion in modern history here. But what got you involved in artificial intelligence, and what motivated you to pursue a career in this and machine learning?
So I first started getting into AI back in late 90s, early 2000s, when I was a high school student and then a college student at Rutgers and UC Berkeley, where I went to shortly after. I was really excited about how AI brings together both really cool applications, but also some very deep mathematics. And my first couple of use cases that I focused on first was in the financial domain, and then in web search through the through some early internships at Google. And then I continued really diving deep into AI. I did AI research when I was an undergraduate at UC Berkeley, and then went to do my PhD at MIT. And the AI that I was thinking about at the time was, how do we build computers that can reason like humans reason, recognizing that we were incredibly good at making inferences, doing deductions, but computers typically are not very good at that. So that was the major focus of my AI research when I started my career. When I then transitioned to becoming a faculty member at NYU, I was looking for a application of AI where I could have one foot in an application with real deep social impact and the other foot in the more theoretical side of AI, where we could push the boundaries of AI techniques. That's when I landed in AI in healthcare.
Yeah, and that's an amazing journey to think about, all those touch points, and certainly the foundation and underpinning of all of that is math. So those of us that have been working in AI know that math is at the beginning and the end of all of that. So it's great to hear you say that. And I was almost a math minor in college, and I wish I would have just taken it, because it would have given me maybe another little extra insight into all this work now. So I can't help but ask the sort of evolution of your career academic-wise, and in coming to this space in healthcare, which of course has led you to Layer Health. But before I ask that, what have you witnessed and what have you experienced as your major challenges with AI in healthcare and working in this space? Again, another easy question, but
Yeah. You see me through the video looking like, that's a good question. Yeah, so I'll have to start from the academic lens, because that's really where I began here. I had been fortunate at MIT to have incredible collaborations with health systems and health insurers, and with that came access to data and a clarity of problems, which if we could solve would have a big impact in healthcare. But then the translation of those into clinical practices that goes beyond the small number of health systems insurers that I work with was always one of the biggest blockers to bigger impact. That actually, I would say, guided a lot of my research. My research then looked at what could we do on the AI side that would actually accelerate that translation and scale.
Interesting. How's all that informed Layer Health, and what is Layer Health mission, objective, and what are the products and services that you were working on in Layer Health that are sort of being pushed out into the health space right now to solve problems?
Layer Health aims to become the AI layer for healthcare.
Explain that a little bit for our audience, because I have some ideas on what you mean by that, but it may not be as intuitive for those that have not been working in the AI space. Where you talk about layers, that's a very common metaphor. But
So I'll walk you through that. I'll walk you through that, and I'll then return to your earlier question though. So by AI layer, initially we're tackling this problem of very deeply understanding what's going on with patients, what's happened to them in the past, what's going on with them now, and what's going to happen to them in the future. And building a layer of information, high quality, validated information about patients that all other aspects of medicine and healthcare can build on top of. So when we first started tackling this problem, it was about 2012, when I was working very closely with one of my co-founders of Layer Health, Stephen Horng, who's a physician at Beth Israel Deaconess Medical Center. He's trained as a computer scientist, did a clinical informatics fellowship, and practices in emergency medicine at that hospital. We started thinking about really how we could bring AI into the emergency department, where there were a number of challenges that the clinical community would come to us with, saying, okay, you do machine learning. These problems look like they are just ripe for machine learning. They were typically of the nature, right? Help with diagnosis, help with risk stratification. An early example, something we worked on, was early detection of sepsis, which of course today is a very commonly discussed application of machine learning in healthcare. And as we tackled these early use cases of machine learning, what we realized is that the impact was going to be relatively small because machine learning from a predictive perspective only provides a small improvement over what you could have done with well-known clinical decision support rules that clinical community had been developing for a long time. But what was much more important was really how do you get those instruments into the clinical workflow at the right time, and what do you do with the predictions is what would have a much bigger impact. And so what we ended up pivoting to through our research was this information problem that is what led to Layer Health, where we realized that if we could get the right information at the right time, that would be transformative. And I'll give you a couple of early examples from our research. That hospital system had a large number of decision pathways. One example would be a cellulitis pathway if a patient suspected of having cellulitis. Another example would be patients who have cardiac etiology, so patients coming in plenty of heart-related problems. You know this better than me. Other examples include identifying patients who are at fall risk so that when they're being transported from place to place, one can use fall precautions. For each one of these examples, there are well-established best practices that if you knew the patient fit into those categories, so had suspected cellulitis, had a cardiac etiology, was likely to have a fall risk, then you would want to surface decision support at the right time for the clinical team. But none of those elements were recorded in structured data anywhere in the electronic medical record. And so there was no way to trigger decision support at the right time or in the right part of the workflow. What we realized is that if we could predict clinical state variables, summarize those elements and more in a high accuracy way at the point of care, then we could just build the next generation of electronic medical records on top of that information. That's what we set out to do. And that's just only one example. The next step of the research started thinking through, okay, if you are now going to rethink documentation and how we start to do pre-charting and bringing the right information to clinicians' fingertips for other downstream use cases, how do you find that information? How do you bring that information up at the right time? But the big challenge that we faced in each of these is that there was very little labeled information that one could use to train machine learning algorithms. So machine learning really depends on having a notion of ground truth that you could use to both train and validate your models. And if you don't have good ground truth, then you can't get started. And so typically for each one of these use cases, one has to hire a large number of research assistants at your health system or your hospital to get ground truth, build machine learning models, and then when you want to translate that to a new health system, you have to start from scratch. And that was the real core issue around scalability that I'm alluding to here, which our research and then Layer Health has been transforming.
And how are you overcoming that challenge of scalability? Because that's a really important, observation. You know, with a lot of solutions, and I'm sure you've encountered them not only in your research but in practical application and in development as well over your illustrious career. How do you scale these things? It's great, right? I've run into this as well. You have a really great solution. It works in this one use case, but you can't translate it to another person, or yet alone a population that may have similar characteristics. So how did you overcome, and how are you overcoming that scalability challenge with Layer Health's solution?
So today we're focused on clinical notes or unstructured clinical data. And the way we get around it is by not having to do labeling at all. So completely skipping that process. We can do that with large language models because we have the opportunity now to have someone come in, a clinical expert, say, we need to abstract this specific information about a patient, but not just one patient, but maybe thousands or hundreds of thousands of patients. And one could say that in words, and our models now are good enough that we can take that English language description, couple that with the language written in the clinical notes for all of those hundreds of thousands of patients, and immediately immediately get the right results, get to do the abstraction, because we understand language so well. So we no longer need to do that huge amount of work up front to label a ton of data or to learn machine learning models to do that.
One of the things that I've come to appreciate in the innovation space, particularly with technology and healthcare in particular, is that there's sort of three criteria that need to exist, in my opinion, my humble opinion, for making a technology very successful, particularly in the healthcare space of the U.S. healthcare system, because we have a very unique healthcare system. So scalability is definitely one, because if you have to individualize and have to reinvent your solution for every single use case, as I mentioned before, it becomes very laborious, and you alluded to that as well. And it's not practical, right? Because you can't really make a lot of traction there. So you've hit on the scalability part. The next thing is validation. Obviously the holy grail in healthcare for, the drug companies have shown us this well, is to get FDA approval, because then that there's been a third party sort of non-biased, unbiased, opinion that has rendered this solution, application, therapy effective, safe, and equitable, hopefully. And you talked a little bit about the validation part. So I'm going to ask you to delve into a little bit more there. And then the third part is who's going to pay for it, because when you want to operationalize something, you just need resources. That's just the unfortunate truth about whether it be healthcare or whatever industry you're in. Someone has to pay for it, not only because you need obviously to be compensating the people that are developing the technology that are doing something good for society, but because you need that resource, or you need those resources to keep refining, developing, and improving whatever your solution is. So you talked about the scalability part. Let's talk about the two other aspects, though. The validation, like how is Layer Health validating, getting to the ground truth you talked about, and making sure that the solutions you are providing for these sort of applications that are getting the right information for the right patient at the right time into the hands of those that can actionably use that, for the good patient. How are you taking care of the validation part? And then, after that, just talk about a little bit of the reimbursement part, because that's also a very tricky thing. Healthcare is one of these, U.S. healthcare in particular, is one of these very unique industries where both provider and sometimes patient, if not more, are just totally agnostic to the cost. You just go and there's a transaction that occurs, but there's no money exchange. There's nothing really exchanged other than, at least for the most time, just insurance information. But as you and I both know, there's a lot of cost that's involved in that transaction, even though it may be completely opaque to those that are in the transaction at the time. So yeah, let's talk about that, the validation part for Layer Health, and a little bit about your business model for the reimbursement.
Great questions. I agree with actually all three of the points that you raised in terms of them being the critical elements for a successful company and impact. So on the validation side, our starting point here is that there is no one size fits all solution for healthcare, and every need is going to be a bit unique. First, what we're enabling is that our users, for example, within health systems, can very quickly validate for themselves that the results are what they expect them to be, without having to do a very expensive and manual process for validation. So think about it as our platform as making it fast for, after once you recognize you need to do chart review for a particular data element from a particular predefined population, how do you very quickly review the results across a large number of patients? Think about like a sample of the population to recognize whether the results are what you expected them to be. And then how do you monitor it over time, getting back to this safety, long-term efficacy question. So if we can enable our customers to do that themselves, then we can start to remove one of the bottlenecks in scalability, which is expecting that the vendor is going to always have what they need for their particular use case. This, we think, is going to allow for an enormous amount of scalability in the healthcare system. And so if we think about now regulation, you alluded to FDA approval a second ago. That's going to be a really interesting space to watch in AI and healthcare. But I think that starting to look at the processes by which one builds the models, validates the model, and then monitors the models is going to be where we're going to end up sitting. So we're building the right process. And then if you can validate that process and make sure that that leads to high quality data and safe patient outcomes, then that then gets you both the validation component, but also the scalability at the same time. And then finally, I'll mention that there are some, despite the fact that I mentioned that there is no one size fits all solution, there is some amount of validation that we can do on the layer health side that is going to provide confidence to our customers that our models are accurate and reliable. And that's something that we're investing very heavily on our side, and we'll be continuing to do so. So rather than thinking about it as saying we are validating this one, that we can abstract this one data element very well everywhere, we're now looking at it at scale. We can abstract these thousands of very distinct data elements very accurately, and that's the level of validation that we're doing.
And it would seem to me, and correct me if I'm wrong, that your validation needs even further reinforced by the fact that if folks are using your solution, they're working in partnership with Layer Health, and they're noticing that there's a decrease in, patient safety issues like falls and things like that, and there's an improvement in the detection of early sepsis and the prevention of, a cardiac event. When they're working with you, all those numbers are improving, the outcomes are improving. I would think that would be, the best validation of all, obviously.
Absolutely. And most importantly, that validation that's happening at one health system is then going to impact other health systems. And so we're creating a network effect that we think is going to lift up healthcare for everyone in the US.
Absolutely. Well, that's fascinating. That's great. Great work. So getting to the, the very important issue too, especially from a company standpoint, with the reimbursement. So there is obviously an incentive for the hospitals, the organizations that work with Layer Health to make the investment in getting better information, because you can make better decisions and you can apply that decision-making process in a more effective way to improve the outcomes of your patients. So clearly there's an incentive there. But beyond just the healthcare organization and the system as a customer, who else can you sort of envision being a customer of Layer Health, and how else could there be remuneration for, the great work that you guys are doing?
So I'll start out by talking about the health system side, and then we'll move beyond that to talk about pharma and the payer world. So on the health system side, what we've been hearing from our customers, partners, and folks who just express interest in what we're doing, there are three buckets of use cases where we're going to see short-term ROI for Layer Health. The first one is on quality improvement. The second is on getting patients to the right side of care. And the third is on care standardization. On quality improvement, that touches on how can we measure what's working in healthcare so that one can use that information to drive quality improvement efforts. As an example of what we're doing in that space, we're working with a health system in Wisconsin called Frederick. They're associated with the Medical College of Wisconsin on doing chart abstraction for a surgical registry. I imagine you're very familiar with.
Yeah, right. You piqued my interest.
Maybe you could tell me a bit about the surgical registries that you know about, and how you hear about their use and sort of what the data points are from your side.
Oh, absolutely. I mean, in quality improvement, that is not that is sort of the foundational element that you need. Registries, right? Because you need to track what you're doing in surgery. So I don't want to digress too much, but I'll just briefly mention the Society of Thoracic Surgeons database is something that existed, well before everyone was talking about AI. And surgeons, as you can imagine, cardiac surgeons in particular, we have a specialty in which the stakes are very high for us. When you operate on the heart, there's very little margin for error. As a profession, as a society, and as a discipline, we decided long ago, decades ago, back in the 80s, as a matter of fact, to report our data and report our outcomes and to share it with not only our community, but then even outside of our community. And what that did was, as you can imagine, David, you started to see outliers, right? You started to see the really excellent performing centers and individuals, and you also saw some that were not performing as well. And what we could do from that is, because everyone's reporting this data and their outcomes, they're also reporting the things that they're doing for a particular surgery. Are they giving blood transfusions? Are they giving antibiotics before a case starts? Are they doing different things on the bypass machine that other centers are not? And over time, as we started to validate why some centers are working better and some programs are working better than others, you started to get a little bit of an equalization. The things that the best centers were doing, or the high-performing centers were doing, now we can start modeling that with all the other centers. And over time, you started to get a very predictable outcome with something very complex like heart surgery. And that was because we're sharing information. It seems like so basic, right? But can you imagine that wasn't being done? And I would like to argue biasly that, cardiac surgeons were at the helm of that. And now, of course, you have the national standard, quality improvement initiatives through the American College of Surgery and all kinds of other societies that are mimicking that model, which very, very basic model, like let's take your outcomes, let's report them, blinded, of course, and then take all that information and then see what are those factors, what are those variables that those very good or high-performing centers are doing, and what are the things that those centers that are not doing so well doing as well. And now let's find mitigation strategies for those centers that are not doing some of the things that the high-performing centers are doing. Let's start doing those things, and let's start eliminating some of the things that probably are contributing to poor outcomes or not so good outcomes in some of those other centers. And it's remarkable how it works, and it's been a very cooperative and very robust way for quality improvement to permeate through the ranks of cardiac surgery.
So I couldn't imagine a better setup for what I'm going to say next.
Oh, great. All right, perfect.
So surgery really has been at the forefront of this. Surgery can do this partly because surgery is expensive and also obviously so critical in terms of patient outcomes that one can justify the large expense that it takes to actually start to gather that data, which is essential to quality improvement efforts. So across different clinical areas, from surgery to cardiology and so on, collecting this data, as I understand it, typically requires a huge amount of chart review. So you have
an army of folks to get all this information.
Exactly. They're pouring through patients' medical records to abstract hundreds of different data elements that summarize, of course, not just the outcomes that you alluded to, but also what happened during surgery, what were the indications for surgery, what are other comorbidities the patient might have that might have, if you're thinking about comparing across different hospitals, might help you better compare apples to apples. And so you need that army, as you referred to it, of individuals to help do that chart abstraction. And that's the part which is just not scalable in healthcare. So it costs a lot of money. Some of the same people who would be doing that work, these very high qualified nurses, are also the same people who are in short demand in the US healthcare system, where we have a huge nursing shortage. And so as we think about really how do we not only scale that up within surgery, but also how do we go to lots of other clinical areas where these same quality improvement efforts could be transformational to healthcare? And how do we then also start to get at the most important information? Because in some areas, one takes structured data because it's what you can collect cheaply and easily, but it's not necessarily measuring what really matters. So imagine now that you had the ability to do chart review scalably, cheaply, and very accurately using AI, how can you start to rethink what the next generation of registries are going to be like and what new quality improvement could look like? That's what we're doing in this front.
That's amazing. So, those three buckets that you mentioned, this is a perfect use case for all of those things. So what are the buckets number 2 and 3? So the first one, of course, quality improvement. We touched on that. I think we continue to use this as a really good, sort of use case for going through those other two big buckets of where you guys have seen Layer Health's solution being, very attractive to folks.
All right, let's talk about bucket number 2, site of care optimization, and routing patients to the right place at the right time.
Yes. So so now we're going to have a nice riff here, right? Siting patients to the right place at the right time, basically providing the right care for the right patient at the right time. In other words, that database not only has helped us to improve outcomes, but it's helped us to create a registry, from our registry rather, an ability to predict what someone's outcome is going to be. And so we can actually help triage them to the right kind of surgery or non-surgery, if necessary, based on the patient's sort of profile. How old are they? Do they have any comorbidities? Are they going to be a good candidate for surgical intervention? Or are they a better candidate for perhaps a medical intervention or something that was, maybe not as invasive? Or something that may not, lead to as much risk and harm. So talk a little bit about that.
This is great. Great. I'd say on the last point you made, we'll come back to that when we talk about care standardization, because those realizations I think have often led to new clinical guidelines that we can then talk about. Well, how do we actually get those guidelines used for the right set of patients? So we'll come back to the last example in a minute. As relates to routing patients, let's start with another example that maybe is top of mind for you: ambulatory surgical centers. So something we've heard from talking to a number of our customers, current and prospective, is that ambulatory surgical centers, which are places that are outside of the hospital environment that patients can get surgeries, are, when suitable, much better for patients, better patient experience, can lead to better outcomes given that you're sort of away from the hospital environment, maybe risk of infection is lower, and are also much more scalable because there are ways, if you can get surgeries that don't need the complexity of the main hospital environment outside of the environment, then a lot of the surgeries that are much more complex now suddenly have beds and capacity to take on. But not all surgeries are appropriate for ambulatory surgical centers.
You're absolutely right. And what you're saying is absolutely true as well. I mean, we see this in practice. For some patients, relatively healthy, not a lot of comorbidities, they have one specific thing that needs to be addressed. And orthopedic types of things come to mind. And, this is a one kind of isolated issue that's causing the patient a lot of morbidity in terms of not being able to be functionally as well as they want to be. And then you can just address that one thing and then that's it. And so ambulatory centers work well for that, or a patient that just needs a port or a device so that they can get the therapy that they need for maybe another condition that's a bit more chronic. Another good use case for that. But then, as you mentioned, there could be patients that have a lot of comorbidities. They have, risks for anesthesia. They have other challenges that might, if something were to go wrong in a pretty simple procedure or a relatively elective procedure, the consequences could be pretty high if they're not in a tertiary care center where they have all the resources, all the specialists that can come to bear and intervene when appropriate. So you're absolutely right. And of course, if you can distinguish and triage where those patients need to be at that time, that helps unburden the organization, the healthcare system that's trying to take care of all these patients, all the comers, when some people may be better served in an ambulatory care environment.
Maybe we can dive a bit deeper into the orthopedic example you gave. So what are factors that, if you were thinking about scheduling orthopedic surgery, you might want to know to help you decide, should this go one way versus another?
Oh, yeah, sure. Do they have a difficult airway? Have they had problems with anesthesia before? Do they have kidney disease? Are they on dialysis? These types of things where may not be the best suited for an ambulatory care environment. But if it's someone relatively healthy, the only thing they have is, a knee issue that just needs to be addressed. Perfect candidate for that, because now, they can just go in, probably very little risk of them having any complications, and then they'll have the intervention they need and now can go on to rehab and get back to a functional state much faster without the risk, like you said, of subjecting them to a whole hospital environment where they're, higher risk for infection and, other things that could happen to them while they're there.
Right. So each of those elements that you enumerated, difficult airway, previous problems with anesthesia, kidney disease, each of those is an example of something that we would want to be able to extract from a chart. And if we could reliably do chart review to answer each of those questions, and there's a much larger number, then we could get the information to the fingertips of the person helping decide, where should this surgery be scheduled, and hopefully get the better route the patients to the right location. Another example here would be around hospital at home programs. That's been getting a lot of uptake here in the US. This is an example where the criteria for which patients you might be able to service well in a hospital at home program might be changing over time as a health system becomes more mature and increases their capabilities and technology that they can use to help patients stay at home. And so identifying the relevant patients that are appropriate at this point in time with the current capabilities is a very challenging problem with rollout. And this is exactly analogous to the ambulatory surgical center example that I gave.
Yeah, that's great utility for everything you're talking about. And I want to move on to some larger issues, but we have to stop here. Also coming up next time on the podcast, David Sontag, the co-founder of Layer Health, will share his optimism for the future of AI in healthcare.
There's a will among academics, among industry, among health systems, among government, and among patients. The fact that I think there's a will now to actually do it means that we can start to dream as a society about not what healthcare is like today, but what it could be like tomorrow.
This has been Smarter Healthcare with AI. If you'd like to find out how to bridge the gap between medical experts and tech innovators and discover how AI can make us healthier and more human, go to Tetteh.com. Smarter Healthcare with AI with Dr. Hassan Tetteh is a production of Forbes Books.